So we're going to start with, oh, hold on. Let me get off that. Okay. We're going to start with the endocrine system today, and we're going to do endocrine and GI before we take a break. So that's quite a few slides. So we're going to move along at a decent clip so we don't get too far behind today. And we'll start. So let's talk a little bit. Okay, you can leave it at that, or you can go back one, Devin. I just got to say something about endocrine first. Thanks. So in the endocrine system, as you should know, the endocrine system is comprised of organs or glands that secrete hormones, and they release the hormones into the circulation. It's easier to remember the endocrine system if you think about hypersecretion of these hormones or hyposecretion. That's going to help you in terms of answering questions. If you have a hormone secretion excess or hypersecretion, then it's blocking the release because of medications or perhaps because of surgery. If you have a hormone deficit or hyposecretion, then you're going to need replacement therapy. So if you think of hypothyroidism, what's going to happen? You're going to need to take some thyroid hormones in terms of medication. If you have a hyperthyroidism, then you may need to have all or part of the thyroid removed, just giving you that example. Okay, next slide. Okay, sildenafil citrate is prescribed to treat a client with erectile dysfunction. The nurse reviews the client's medical record and would question the prescription if which is noted in the client's history. 1, insomnia. 2, neuralgia. 3, use of multivitamins. 4, use of nitroglycerin products. Lots of allergy here too. And Paul? Absolutely. Use of nitroglycerin products. Now, why is that? Think to yourself why that would be. That would be the reason for its nitroglycerin products is because of what does the sildenafil do? What does the Viagra do? It allows greater blood flow to the penis. What does nitroglycerin do? It allows greater blood flow to lower the blood pressure. You put the two of these together and you can have a severe and potentially fatal drop in the blood pressure. Next slide. An adolescent with type 1 diabetes mellitus who joined the cheerleading team needs to learn how to maintain a stable blood glucose level with increased activity. What information should the school nurse provide? Eat 6 graham crackers before practice or game time. Eat half the amount of food normally eaten at lunchtime. Take twice the amount of prescribed insulin on practice and game days. Take the prescribed insulin 1/2 hour prior to practice or game rather than in the morning. And Paul? Excellent again. Eat 6 graham crackers before practice or game time. Now, again, you need to know the why. Why is she going to do this? What she's doing, or he, is they are expending energy when they are cheerleading. So if they are expending energy, they're going to need to have something just before game that will give them some additional energy. So we talk about diabetes mellitus. I said earlier about hormone excess or deficit. What is diabetes mellitus? Is it glucose deficit or is it glucose, increased glucose? So it's a hormone deficit. So therefore you need to replace the insulin. It is a chronic disorder of impaired carbohydrate, protein, and lipid metabolism. It is due to what? Now you know what it's due to. It's due to absolute or relative deficiency of insulin. Next slide. A child with diabetes mellitus suddenly becomes flushed and reports dizziness and a headache during gym class. The school nurse measures the blood glucose and the results are 60 mgs per dl. What is the most appropriate initial nursing intervention? Give the child 6 ounces of orange juice. Call the school healthcare provider immediately. Call the child's mother for permission to treat the child. Let the child rest until the glucose has had a chance to rise. Nicole? Yes, positively. Excellent, excellent, excellent. Give the child orange juice. This child has a blood glucose of 60. You need to immediately treat them. So in terms of the school healthcare provider, if it continues, yes, you might call them. Calling the mother, you probably will not need to do that because if when a diabetic child comes into school, all of the paperwork is already filled out, allowing the school to treat the child. Letting the child rest is not going to change the glucose, and it needs to be brought up immediately. Next slide. We stuck here?
I've moved it forward. I have the question, the nurse provides instructions.
Oh, okay, I'm sorry. I was looking at a different thing in my notes. I'm sorry. The nurse provides instructions about sick day measures. Probably have already answered this. With the mother of a 7-year-old child with type 1 diabetes mellitus. The mother indicates an understanding of the instructions by stating to take which action if the child's blood glucose is greater than 250 and urine tests are positive for large amounts of ketones. Should the mother what? Should she stop administering the insulin? Contact the healthcare provider for further instructions. Cut down the amount of food by half each meal. Encourage consumption of high calorie and high glucose fluids. Paul? Excellent, excellent, excellent. Yes, the answer is number 2. Contact the healthcare provider for further instructions. And the reason it is not number 1 is that a mom is not in the position, or a nurse, to stop administering the insulin without first talking to the healthcare provider. And of course, you can see that both 3 and 4 are similar because they both talk about food. And what do we say about answers that are alike or similar? It means they're incorrect. Okay, next slide. Okay, now we're going to talk about Addison's and Cushing's disease. This gets very confusing to people sometimes in terms of what you're looking for. So as I said the other day, we're going to talk about, I'm not going to read every slide, but this is what you need to know. And if you have a notebook, take this down. So in Addison's disease, the steroids are low. So the client is going to be small and they're going to be thin. They'll have GI disturbances. And as you can see, they'll have weight loss. They'll have orthostatic hypotension. The difference in Cushing's is that with Cushing's, in Cushing's, they're usually big, round, hairy, weight gain. They have that very particular look, which I believe we'll have a slide in a few minutes showing you the truncal obesity that these people have. They'll have truncal obesity, but they will have very thin extremities. Moon face, and usually a buffalo hump. So here's a tip. When you think of Addison's, ADD Addison's, think add. So they've got a low BP, low weight, low temp, low hair growth. Then you need to add those things when you talk in terms of medication. The thing that is different here is you have low sugar, hypoglycemia. The only thing that is different is that your two highs are your potassium, hyperkalemia, and your calcium. Your potassium and your calcium in Addison's are the only things that are high. Everything else is low, and therefore you're going to want to add. When you think about Cushing's disease, use again the beginning of the word, cush. These people are cushy. They have too much. They're too cushy, they're larger. So any treatment is going to be to reduce that. And I hope that makes sense. Next slide. And here you can see the normal skin color versus the hyperpigmentation in Addison's disease. So again, Addison's disease is a hyposecretion of adrenal cortex hormones. Cushing's is a hypersecretion of glucocorticoids. Next slide. So here is your slide on your Cushing syndrome, what I talked about. Notice this woman's trunk, how she has this very pendulous abdomen, but very thin legs. Scalp hair is usually very thin. They have increased body hair and facial hair. I talked about the moon face, very thin extremities again, and easy bruising too with Cushing. So think about your words and use those to help you remember as you prepare for NCLEX. Next slide. Okay, so we're looking at here Chauvet sign and Trousseau sign. And those are signs of hypocalcemia in Cushing's disease. Now, when I would teach students this face-to-face, I would say, tap on your face, which I'm sure a lot of you are doing. If you had hypocalcemia, your face would start to twitch, as you see in the picture. In terms of Trousseau sign, is when you taking someone's blood pressure, and the way you test for Trousseau sign is you pump that blood pressure cuff up to about 20 millimeters of mercury above what their normal systolic would be. Leave it on for a couple of minutes, and if it is an issue, you will see, as you see in the picture there, that carpal kind of spasm where the hand will spasm, just like you see in the picture there. Keep wanting to say any questions. Like I said the other day, if you have questions, this is a lot of information to absorb. Please feel free to type them in the chat or make a note of them. And at the end, we can take a look at any questions that you may have. Next slide. When receiving, somebody going to say something? No? Okay. When receiving intershift report, the nurse notes that an assigned client has a diagnosis of Graves' disease. The nurse should include which measure in the plan of care: a high fiber diet, extra heavy blankets, quiet, restful environment, 4 small meals, and a bedtime snack. Oh. And poll. Okay. So a little bit all over the place here in terms of meals, extra heavy blankets. So you need to know what is Graves' disease. Is it hyper or is it hypo? Graves' disease is hyperthyroid. So what do we say when there's too much of a hormone, too much going around? It's hyper. So these people with an oversecretion of their thyroid hormones they're nervous, they're shaky, they have a high sensitivity to heat. So if you know that, then you leave out the heavy blankets. They often have difficulty sleeping or resting. So the answer is, which most of you put, a quiet, restful environment. So if you have trouble with this, I would suggest you look in your endocrine chapter of your NCLEX book, and it's very nicely spelled out there. Okay, and here is a very good pictures, I should say, of Graves' disease. Now, if you look particularly at the thyroid gland in the neck of the woman on the, actually both females here, note the increase in thyroid gland. Now, what did we say in the beginning about increase or hyper? If it's hyper, you want to do something to reduce it. And in this case, it most likely would be some sort of thyroid surgery. They might try medication, but some sort of thyroid surgery to reduce the thyroid or remove the thyroid in this case. So hyperthyroidism, if it's hyper, you want to reduce things. So going to the last question, you want to reduce the stimuli and keep them restful. Next slide. Okay, propylthiouracil is prescribed for a client with hyperthyroidism, and the nurse reinforces medication instructions with the client. The nurse should inform the client to notify the healthcare provider if which sign occurs: polyuria, dry mouth, sore throat, drowsiness. Okay. And Paul? Interesting. Most of you got the answer correct. And the correct answer is sore throat. Now, why? So sore throat is a side effect of PTU, or propylthiouracil, and it could be a sign of agranulocytosis. Now, if you know what agranulocytosis is, of course, and it is severe leukopenia or a drop in white blood cells. And with PTU, one of the things you may see as not a side effect, but an adverse effect is a sore throat, and therefore that has to be reported to the healthcare provider. And excuse my voice, allergy season in the Northeast. So, okay. Here is just a photo to show you the edema of the eyes and the face in hypothyroidism. So in this case, it's hypo. What are you going to need here? You're going to need thyroid replacement. Okay. Okay. Do some more questions. The nurse provides instructions to a client taking levothyroxine. The nurse determines that the teaching was effective if the client states to take the medication by which method? With food, at bedtime, at lunchtime, on an empty stomach. And Paul? Excellent. Excellent. You clearly have a good pharmacology teacher. So why? Because it's not enough to just say empty stomach, but why on an empty stomach? And the reason is because it's used for a thyroid hormone replacement. So it needs to, the stomach needs to be empty because the absorption of the levothyroxine can be decreased if any food or other medications are in the gut at the same time. So in order for it to metabolize properly, it needs to be taken on an empty stomach. Next slide. Okay, same med. The nurse provides medication instructions to a client taking levothyroxine. The nurse instructs the client to notify the healthcare provider if which occurs: fatigue, tremors, cold intolerance, excessively dry skin. Okay. Great work. Tremors is the answer. So in terms of the other things here, the tremors, think about tremors and what causes tremors. Tremors are caused by a problem or an issue in the neurologic system. So you need to notify the primary healthcare provider or who prescribed the meds, because tremors with levothyroxine, make a note or star it, is a sign of toxicity with levothyroxine. A client is seeing the healthcare provider for complaints of fatigue, a lack of energy, constipation, and depression. Following diagnostic studies, hypothyroidism is diagnosed. Levothyroxine is prescribed. The nurse should tell the client that which is the primary expected outcome of the medication: alleviate depression, increase energy levels, increase blood glucose levels, achieve normal thyroid hormone levels. Okay. Excellent. Excellent work. Achieve. So think about it. What is it? We talked about this. Levothyroxine is for hypothyroidism. It is to help to replace what is missing in the thyroid hormones. So the primary, and again, it says primary, the primary what we're looking for primarily is to achieve normal thyroid hormones. Great job. A client has just been admitted with a diagnosis of myxedema coma. The nurse would place highest priority on completing which prescription, and remember in NCLEX, we used to call them doctor's orders, they're doctor's prescriptions, not just a pharmacy prescription. The nurse would place highest priority on completing which prescription: warming the client, administering oxygen, giving fluid replacement, administering thyroid hormone. Oh, thank you. Okay, impulse. Okay, interesting. Highest priority. So when you see something like highest priority, if you're not sure, and answers are a little bit all over the place, sort of between the thyroid hormone and administering oxygen. So this person is myxedema coma, not mild hypothyroidism, severe hypothyroidism. So if you look at a question like this and you say, I'm really not sure what the answer to this question is, think first, ABCs: airway, breathing, circulation. That brings you directly to number 2, which is administering oxygen. So myxedema coma, or severe hypothyroidism, what it does is it leads to a decreased mental state. It also leads to hypothermia, the slowing of multiple organs. Now, the people that put warming the client is, well, Eileen, you just said hypothermia. Yes, but what it says in the question is highest priority. It doesn't say you're not going to warm the client. It says what is the first and highest priority thing you will do for this client as a nurse. The coma can be precipitated by an acute illness, rapid withdrawal of thyroid medication, anesthesia and surgery, which can affect many things, hypothermia and use of sedatives, and opioids. So again, if you're not sure, so warming the client, yes, you're going to do that. Thyroid hormone, yes, you're going to do that. If they need fluid replacement, yes, you're going to do that. But what is the highest priority here? The highest priority is your ABCs. Administer the oxygen to the patient. Thank you. Next slide. A daily dose of prednisone is prescribed for a client. The nurse provides instructions to the client regarding administration of the medication and tells the client that which is the best, strategic word, best time to take this medication. At noon, at bedtime, early morning, anytime, but at the same time each day. Cool. And Paul? Early morning, absolutely correct. And the reason, now there's always a why, there's always a why. The reason for early morning when you are giving, when you're giving a daily dose of prednisone is because it mimics the normal burst of glucocorticoid secretion in the early morning. So we all have a normal burst of glucocorticoid secretion from overnight. So therefore you want to give it early in the morning. Next slide. I think we're going to flip here. Yes, so back to diabetes mellitus. A client newly diagnosed with diabetes mellitus, think now, newly diagnosed, has self-injected insulin, NPH insulin, at 7:30 a.m. The nurse reviews timeframes for peak insulin action with the client, explaining to be especially watchful for a hypoglycemic reaction between which times? 7:30 and 9:30 p.m., 1:30 and 7:30 p.m., 9:30 a.m. to 11:30 a.m., 10:30 p.m., and 7:30 a.m. And for intermediate acting. Devin, can you see how they've answered in terms of numbers?
Yeah, I can see.
Okay, so you can just flip off the poll once they've mostly answered?
Yeah, sure.
Good, okay. Okay, so I would say that it would behoove you all to, or most of you, to review your short-acting insulin times, your intermediate insulin action times, and your long insulin peak times. That is very typically an NCLEX question. So in this case, what is NPH? NPH is an intermediate acting insulin. So therefore, it's going to have a reaction between 6 and 8 hours or so. So those of you that answered number 2 are correct. If you don't know your times, I would recommend that you circle your notes or make a note of looking that up. Next slide. Okay. The nurse is teaching the client how to mix regular insulin and NPH, insulin in the same syringe. Which action, if performed by the client, would indicate the need for further teaching? Negative question. Withdraws the NPH insulin first, withdraws the regular insulin first, injects air into the NPH vial first, injects the amount of air equal to the desired dose of insulin into the vial. Thank you. Excellent. Excellent. Yes. Why? I'm always going to say why. Why? Why is that wrong? Because if you withdraw the NPH insulin first, and then you take your vial of regular and you inject, you push the air out to the edge of where the NPH is, it's possible that you're going to get the NPH insulin, intermediate acting insulin, into the regular insulin vial. Do you want that? No, you don't. No, you don't, because now you've got an intermediate, if you need to grab a regular insulin, the vial for coverage or something, now all of a sudden that person may get some intermediate insulin within it, the NPH, and therefore it's not going to work as quickly as it should with the regular insulin. I hope that makes sense. Okay, where are we here? Exercise. A nurse is reinforcing information about exercise for a client with newly diagnosed type 1 diabetes mellitus. Which item would be important for the nurse to include in the discussion? Exercise just before eating a meal, administer insulin after exercising, exercise during peak action times of insulin, monitor glucose levels before and after exercises. Perfect. Perfect. Especially a client that is newly diagnosed, as this says, a newly diagnosed client is going to need some real teaching about their diabetes mellitus. So yes, they should monitor glucose levels before and after exercise. Somebody that's been a diabetic for a long time, I will tell you from family experience that they get used to how their body feels, what their blood sugar is doing, and they are able to better monitor without doing it both times, but newly diagnosed. Now, these last few slides and the couple coming up should tell you something. Know diabetes mellitus, know your insulins in terms of NCLEX questions. Next slide. The nurse is discussing foot care with a diabetic client and spouse. The nurse includes which statement during this informational session? File toenails straight across. Use strong soap to decrease skin bacteria. Soak feet in hot water to decrease the risk of infection. Apply lanolin to dry feet, especially the heels and between the toes. Oh. Okay, so the answer to this question is file toenails straight across. Because nobody put strong soap, true. Nobody talked about hot water. Both of those would relate to diabetic neuropathy. A person would not be able to feel how hot the water is. In terms of lanolin, now this is a little bit tricky in this answer that 63% of you put. And the tricky part of the answer is that the entire answer has to be correct. So you are not going to apply lanolin between the toes. You'll apply lanolin to the dry feet, the heels, but between the toes, you do not put lanolin on. You don't want that rubbing. You don't want that moisture in between the toes. So when you think of an answer, remember the entire answer has to be correct. Next slide. A client newly diagnosed with diabetes mellitus is learning about management of insulin therapy. The nurse should include which item of information when discussing self-management with the client. Extra insulin is needed prior to heavy exercise. All insulin vials should be restored in the refrigerator. a systematic plan for site rotation should be followed. When acetone is present in the urine, less insulin should be given. Excellent. So a systematic plan for rotation should be followed. Again, I'm going to say why. Because of something that I believe you'll see in the next couple of slides is something called lipoatrophy. If you were to inject insulin in the same spot all of the time, eventually all of the tissue would just atrophy down. And we'll show you a picture of that in a few minutes. So there has to be a systematic plan for rotation of sites. Okay, I was just looking to see if I had anything else in my notes. Okay, Lispro. Lispro insulin is prescribed for a client. The nurse should instruct the client to administer the insulin at which best time. Now, again, you need to know your insulins. 30 minutes before eating, 45 minutes before eating, 60 minutes before eating, immediately before eating. Little bit of all over the place. Okay. So make yourself a note and put on the note, put Lispro insulin. Lispro insulin is a very rapid acting insulin. Therefore, it is given immediately before eating. The onset of Lispro insulin is about 15 minutes or a quarter of an hour. The peak is 30 to 60 minutes. So if you give it 60 minutes before eating, it's already going to be at its peak before the person even eats. So the duration of Lispro is about 5 hours. So again, Lispro is rapid acting, onset of action within 15 minutes, peak 30 to 60 minutes, duration 5 hours, as opposed to your intermediate that we talked about in earlier slides that has an onset of about 1.5 hours, a peak at 4 to 12, 6 to 12, in a duration of 16 to 24. Now, let me tell you before you move slide, let me tell you something else about an NCLEX question with Lispro or rapid acting insulin. A question that you may get, and it may be a case about a client with diabetes mellitus. And the question may be, the breakfast trays are delayed. And if the breakfast trays are delayed, what should you do for your client who is due to have Lispro insulin? Say the breakfast tray is 8 o'clock. And what are you going to do when the breakfast trays do not come up? You're going to delay giving the Lispro. Okay, from Sharice's iPad to everyone. Good, thank you. What's it a mnemonic on? I didn't read the rest of it, hold on. Ah, excellent, excellent, thank you, Sharice. So again, you're going to hold the Lispro insulin, the rapid acting insulin, until the tray comes, okay? Next slide. The client who has been taking insulin therapy for 5 years comes to the health clinic for a routine examination. After noting that the client has lipoatrophy, the nurse should ask whether or not the client implements which action. Now, this should be easy for everyone. Rotates injection sites systematically, injects the insulin at a 45-degree angle, aspirates for blood return prior to injection, swabs the site with alcohol before each injection. Excellent. I was going to say this answer should be easy because we just talked about it a little while ago. What can happen if you do not? And on the next slide, I believe we're going to see a picture of lipoatrophy. Now you notice that indentation there? I can't point to it, but it's indentation in the arm. Thank you. That is from injecting too many times in the same place. It also affects absorption of the insulin, by the way. And I think the next slide, there you are. So this slide gives you an indication of anatomical injection sites. So client can inject their insulin in the anterior and posterior part of the upper arm, as you see there, 1, 2, 3, 4, 5, 6, 7, 8, and same on the other one. So from the arms to the belly to the thighs, or the thighs to the belly to the arms, but rotating the injection sites each day. Now, I'm pretty sure that Devin is the last endocrine slide.
That's it for endocrine. Gastrointestinal is next.
Does anybody want to take a quick 5 minutes, stand up, jump up and down so that you don't fall asleep from my talking? Why don't we do that? Just 5 minutes, not a full break. So it's 11:44. I will see you at, oh, that's my time, at 11:49. And we'll get ready for G. I'm sorry?
8:49 for us.
I know, sorry.
That's all right.
Too much TV. Are we back? How are we doing? Are we back, Devin?
I am. Looks like we've got 56, so that's 54 students, excluding you and I. So I guess we can get
Okay.
started if you want to.
We will. Okay, so next we're going to go into the gastrointestinal system. The gastrointestinal system includes, as you can see on the slide, liver, gallbladder, stomach, pancreas. The location of these is important when you're dealing with, say, somebody that has cirrhosis of the liver. You're going to want to know the location of the liver so you can palpate it. Then, of course, you have the small intestine, including the duodenum, jejunum, and ileum, the colon, cecum, and appendix. Next slide. So let's get right to questions. I've got a couple of questions here. After admitting a 4-month-old infant with a diagnosis of vomiting and dehydration to the hospital unit, in what position should the nurse place the infant? Prone, upright, modified Trendelenburg, or Sims position, which is no longer called Sims, it's called lateral. Okay, interesting. Okay, so a lot of you would place the 4-month-old on their side. 29% said upright, and some of you said prone. Thankfully, none of you put modified Trendelenburg. So think about what is wrong with this infant. What is going on? Vomiting and dehydration. So the 4-month-old tiny infant is vomiting. What happens if you place them in either Sims position or prone position? You run a high risk, particularly in prone, of aspiration. You want to place this infant in an upright position as much as possible. Sometimes if the baby is that dehydrated and still vomiting, sometimes they'll just place an infant carrier seat directly into the crib so that the infant is able to remain in somewhat of an upright position. Upright, because then you're going to prevent aspiration. Next slide. The nurse is reviewing the progress notes in the health record of a child admitted to the hospital with intussusception. The nurse expects to note that the healthcare provider has documented which finding: scleral jaundice, projectile vomiting, currant jelly type stools, pale, colored, and hard stool. Excellent. Currant jelly type stools. And why is that? It's because in intussusception, the bowel telescopes in on itself and it gets trapped. And the trapped section of the bowel can cause some ischemia. And what ends up happening is the mucosa will slough off into the gut. And you will often see, not always, but you will most likely see currant jelly type stools, and that is the NCLEX answer. I'll show you that on the next slide. So here is a picture of intussusception, and you can see here how the bowel has telescoped in on itself there in the middle. And there's another type of NCLEX question that you may get besides the currant jelly stools. I've had some students tell me that they've gotten this type of question, and that is, you are preparing a child to undergo sedation for a barium enema with air in order to pull, if you will, that telescope part of the ball back out. So the child starts off in pain. You go into the room, parents are with the child is suddenly playing. They've gone from crying and screaming to playing. What should you do? What you should do is you should notify the healthcare provider, because there are instances, there's a certain percentage of intussusception that will self-correct, and you don't want to put a child under anesthesia or sedation if it's not necessary. So that's another question that I've had students tell me that they've seen on NCLEX with intussusception. Next slide. The nurse is collecting data on a child with suspected Hirschsprung's disease, which, excuse me, which question to the mother will most specifically elicit information about this disorder? Does your infant have diarrhea? Does your infant have frequent vomiting? Does your infant constantly spit up feedings? Does your infant have foul-smelling, ribbon-like stools? Great. Does your infant have foul-smelling, ribbon-like stools? Now, why would they have that? And well, first of all, let me explain Hirschsprung's disease a little bit. So the Hirschsprung's disease is the absence of certain cells in the colon called ganglion cells. And what happens is when there is no ganglion cells, it causes the muscle in the bowel to lose the ability to move, peristalsis, to move that stool through the intestine. It's often diagnosed. The newborn has failure to have a BM in 48 hours. And the treatment for this is what they call pull-through surgery. And you'll see that, you'll see on the next slide, Hirschsprung's. So I always tell students the way to remember Hirschsprung's disease is if you look at this picture and you see where it says distended sigmoid colon, that's because it's full of stool. That's why it's distended. And then you come down and you have the aganglionic portion, the portion without ganglion cells. And then you see the rectum. So the foul ribbon-like stools are because the stool is trying to get through from that distended sigmoid colon through that very small bottom. And if it's difficult to remember, think about a balloon. Think about blowing up a balloon and holding the neck of the balloon, and you're trying to it's full of water, or in this case, stool, and you're trying to push it through. It's going to come out in a very thin ribbon-like stream. So that is Hirschsprung's disease. Next slide. Okay, so we are now talking about celiac. The nurse determines that the mother of a child with celiac disease understands dietary instructions when the mother states to include which item in the child's diet: corn muffins, wheat cereal, rye crackers, oatmeal biscuits. Excellent, corn muffins. Why? Because in celiac disease, all of the other things, not in celiac disease, all in celiac disease, a person, child, adult cannot have gluten. My husband and my son they're not celiac, but they have a severe gluten allergy. So you learn after a while to eliminate things like wheat, rye, barley, malt, oatmeal, unless it's gluten-free. There is gluten-free oatmeal now, and things that are heavy yeast products. And you're also going to teach the parent or the person, the client, that they need to watch for things you wouldn't think of that have gluten in them. Like, for example, there are many teriyaki sauces that have gluten in them. There's actually baking powders that have gluten in them. So it's the correct answer to this is corn muffins. But when you talk about celiac or gluten allergy, you want to know what they can and cannot have. Next slide. This is a poor baby with celiac disease. And you can see what happened, the huge distended abdomen, very painful, lots and lots of diarrhea, dehydration. They can get very, very sick. Next slide. Okay, staying with gastro and moving to hepatitis. The client is admitted to the hospital for treatment of acute hepatitis B. The nurse reinforces to the client the rationale for which activity level prescribed by the healthcare provider. Bed rest, activity ad lib, out of bed to chair, ambulation 4 times a day. Aha, okay. The answer to this question is bed rest. It's actually bed rest and proper nutrition, but nutrition is not one of the options. Bed rest is the answer. And as we know now, the hepatitis B is preventable by vaccines. It spreads through body fluids. And the reason for bed rest is that these, with acute hepatitis B, and this is acute, remember, read the question, acute hepatitis B, the client is admitted to the hospital for it. Symptoms will include jaundice, dark color urine, fever, nausea, vomiting, and weakness. Now, it often resolves on its own, but you definitely need to, in the hospital setting, need to have the client on bed rest. So make a note of your hepatitis so that you know the differences in hepatitis. I think the next one is a hepatitis question as well. A client with preliminary diagnosis of hepatitis states that the illness began after eating contaminated shellfish. All right. The nurse interprets that this client most likely has contracted which form of hepatitis? Hepatitis A, hepatitis B, hepatitis C, hepatitis D. Great. Hepatitis A is the correct answer. Hepatitis A spreads from contaminated food or water or contact with. So 2 things about this. If some of you have been away, or you've been to resorts, or you've been to other countries where they've said to you, do not drink the water or drink just bottled water, it is because you don't know what the source of the water is, and it could be contaminated. Where I live in the Northeast, there was a restaurant here who, it was one particular evening, and I think it was a long time ago, but I think it was 70% of the people who ate in the restaurant that evening came down with hepatitis A. So of course the FDA and everybody came in looking for what happened, and they figured out through cameras in the restaurant that one of the wait staff had gone into the restroom and not washed their hands. And it was someone that worked in the kitchen as well. And needless to say, that restaurant shut down and never reopened. Symptoms of hepatitis A include fatigue, nausea and vomiting, and abdominal pain. Next slide. The nurse is evaluating dietary counseling on a client. Now we're going to move to the gallbladder with cholecystitis. The nurse concludes that the client understands the dietary changes needed when the client states that which food item is acceptable in the diet: broiled fish, cream spinach, pan-fried chicken, buttered corn on the cob. Excellent. So 83% of you said broiled fish, which is the correct answer. So as much as, because I'm not a big fish eater, so as much as broiled fish, as much as cream spinach, pan-fried chicken, or buttered corn on the cob may sound better to some of us, some put cream spinach. What is in cream? Fat. Fat is in cream. You have somebody with cholecystitis, which is an inflammation of the gallbladder. You're not going to want to give them anything that's fatty. And what is in butter? Fat. So again, the answer is broiled fish. A client was admitted to the hospital with cholelithiasis. Now, cholecystitis, itis is inflammation. So what is lithiasis? Think about that. A client was admitted to the hospital with cholelithiasis on the previous day. Which new finding indicates to the nurse that the stone has probably obstructed the common bile duct? Nausea, jaundice, elevated cholesterol level, right upper quadrant pain. Okay. Interesting. Actually, gallstones cause pain also up in between the shoulder blades. But getting back to the question, the answer to this question is that in this case, the question is asking, it's a new finding, and it indicates that the stone has obstructed. So if the stone obstructs the common bile duct, what happens? The bile can no longer pass through the common bile duct. So therefore, the bile sits there and causes jaundice. So the answer to this question is jaundice. And here you see the gallbladder, the cystic duct there, and the common bile duct. So if you see where the common bile duct is with the arrow there, if a stone is blocking that, then there's nowhere for the bile to go, and therefore it's going to stay, and it's going to then leach, if you will, into the other system. And the next slide will show you jaundice if you haven't already seen it. So that is a picture of jaundice. You'll often see it in the sclera, in non-Caucasians, if you can't see the difference in color of the skin, although you can. But if you're not used to it, look at the sclera of the eyes and also in the mouth. Next question. Okay, moving right along. Now we're into gastrectomy. A client has a subtotal gastrectomy. The nurse explains to the client the need for long-term injections of which vitamin: niacin, thiamine, folic acid, or cyanocobalamin. Okay, the majority of you got it correct. And for those of you that picked niacin, thiamine, and folic acid, what if I was to tell you that cyanocobalamin is vitamin B12? You're going to get the generic name on NCLEX, but you'll never forget this now. People that have had a subtotal gastrectomy will need lifelong injections of vitamin B12 or cyanocobalamin. Next slide. Okay, this slide shows you the difference. We're talking about gastrectomy here. Gastrectomy, vagotomy, Billroth 1 and Billroth 2 are different types of the surgery. So in terms of a vagotomy is a excision of the vagus nerve. Hence, think vagus, vagotomy. It's an excision of the vagus nerve. And what does that do? It decreases the gastric secretions. So remember, gastrectomy can be used for obesity. It can be used for severe peptic ulcer disease, where a lot of the gut has completely eroded, and it can be used for cancer as well. So again, vagotomy is an excision of the vagus nerve, which then reduces gastric secretions. A Billroth 1 is a creation of the anastomosis between the duodenum. So if you take a good look at these, and I'm pretty sure that these photos are in your NCLEX prep book. Billroth 2 is when they suture the jejunum to the gastric remnant that's left. So again, these can be used for weight loss surgery, severe ulcer disease, and also cancers. Next slide. Okay, a client with diverticular disease undergoes a colonoscopy. Following the procedure, the nurse looks for which signs that indicate a possible complication of the procedure: diarrhea and hyperactive bowel sounds, nausea and vomiting, guarding and rebound tenderness, redness and warmth of the abdominal skin. Okay, diarrhea and hyperactive bowel sounds. Okay, so think about this. When you sitting there taking your NCLEX, think about not just the question, but what is the question about? In this case, it's a colonoscopy. Now, I don't know if any of you have had a colonoscopy. I have. And I can tell you that I could no more have diarrhea after the colonoscopy because there's nothing there, because they completely clean out your gut. Redness and warmth of the abdominal skin. Okay, redness and warmth of the abdominal skin. Where is the colonoscopy? It's in the back, it's in your colon. So chances are you're not going to see redness and warmth of the abdominal skin. However, guarding and rebound tenderness indicates a possibility of when they were putting the scope up in through the rectum, they could have perforated something. So there you're going to get the patient that's going to be in pain, and they're going to be very tender. If you palpate their abdomen, lower abdomen into where their colon is, they'll have guarding. So the answer is guarding and rebound tenderness. Okay, this is diverticulosis and diverticulitis. What is the difference? Diverticulitis is an inflammation. And if you take a look at this, diverticulosis, you take a look at this colon, because see those little, the one on the left, see the little pouches there? Those little pouches there that you can see, yes, thank you. Those diverticula can rupture. And how do they rupture? If a person eats a lot of nuts, seeds, corn, it can get stuck in those pockets and cause either infection or actually, if serious enough, could cause a rupture. And I have seen that, although it's fairly rare. So they really have to watch their diet with diverticulosis and diverticulitis. Next slide. A client with ulcerative colitis is scheduled for an ileostomy. When the client asks what to expect about bowel function and care after surgery, which response should the nurse make? You will need to wear a collection device over the stoma. The drainage will gradually become semi-solid in form. You will be able to have some control over your bowel movements. After the stoma heals, you can irrigate the bowel so you will not have to wear a pouch. Excellent, excellent, excellent. So you think of where the ileum is, an ileostomy. That stool that comes out is going to be very liquid, maybe a little pasty, but very liquidy. And there needs to be a collection device worn over the stoma, which horrified my husband, who has ulcerative colitis. But that's not the first thing. That's not the first treatment for ulcerative colitis. It depends on how serious the ulcerative colitis or Crohn's is. So it can start off with diet. It also goes to medication. And then there's also immunologic therapy in terms of infusions, which is what my husband gets. He now gets infusions once a month because the oral medications were not working. And knock on wood, he's doing well. Next slide. This slide shows you the difference in ulcerative colitis and Crohn's disease. And one of the things you want to know is Crohn's disease, you have healthy parts of the intestines that are mixed with inflamed areas and can occur in all layers of the bowel. So Crohn's can occur in all layers of the bowel, whereas ulcerative colitis is only the innermost lining of the colon. And is very easily seen, well, both very easily seen on colonoscopy. Next slide. Okay. A client has been started on psyllium. The nurse should teach the client to take this medication with which items? A dose of antacid, gelatin applesauce or pudding, a full glass of water, followed by a second, a multivitamin and mineral supplement. Okay. 83% of you got this correct. Nice try, everyone else. But what is psyllium? Psyllium is a bulk forming, like a Metamucil, like a bulk forming medication. And you take it with 2 glasses of water. And the reason you do that is because in order for it to be bulk forming, it has to have the water. It absorbs the water, which causes the bulk, which causes the fiber to assist in having a bowel movement. Next slide. Okay. Staying with the gut and the colon, a client is being evaluated for a possible duodenal ulcer. The nurse monitors the client for which manifestation that would support this diagnosis. Positive fluid wave, distended abdomen, history of chronic aspirin use, epigastric pain relieved by food intake. Nice work. 71% of you got it correct. Epigastric pain relieved by food intake. So here's an easy way to remember duodenal ulcer. Duodenal, diet, both D's. So when you eat, the pain is relieved in a duodenal ulcer. In a peptic ulcer, right in the gut, no. But in duodenum, it's epigastric pain relieved by food. So remember duodenal, diet. Okay. Next, we see a duodenal ulcer and perforation. So you can imagine how, and you can actually see in that, you look real closely in that left slide, you can see the location of the ulcerations, and also the little blue, the location of where the duodenum is in reference to the stomach and the gut. Yes, thank you, that's it. So ulcers obviously are very, very painful. But remember, again, duodenal diet. Next slide. Okay, a client has a PRN prescription for ondansetron. The nurse would administer this medication to the post-operative client for which problem? Paralytic ileus, incisional pain, urinary retention, nausea, and vomiting. Perfect. Nausea and vomiting. So obviously you know in terms of your generic names for your medications, and I believe I know I said it the other day, and I'm sure others have said it as well. You will only get the generic names for your medications. So you need, when you're studying, you need to categorize them like you would your beta blockers, LOL. You need to categorize them and have an idea of what the intended use is, what the side effects are, what the toxic effects are. So in this case, the trade name is Zofran and is typically used for nausea, vomiting after chemotherapy. Next slide. A client has been taking omeprazole for 4 weeks. The nurse determines that the client is receiving the optimal intended effect of the medication if the client reports the absence of which symptom? Diarrhea, heartburn, flatulence, constipation. Great work. Heartburn. So omeprazole is a proton pump inhibitor. It is used to decrease stomach acid. So if you're going to decrease stomach acid, what does stomach acid cause? Stomach acid causes GERD and heartburn, also known as heartburn. And that is what the omeprazole does. Remember the Zol. That's what omeprazole does. Next slide. Okay, moving on to the pancreas. The nurse is caring for a client with chronic pancreatitis. The nurse expects to know which finding that is characteristic of this disorder: fatty stools, excessive hunger, steady weight gain, flank pain on left side only. Okay, the answer to this is, and 65% of you got it right, fatty stools. Remember, when you talk about chronic disease, this is not acute pancreatitis, this is chronic pancreatitis. So in terms of flank pain, which you typically think of as severe, you might see flank pain in acute, but in chronic, someone's had the disorder for quite some time. However, you are going to see fatty stools because of the chronic inflammation of the pancreas. And chronic pancreatitis can be caused by alcoholism. It can be caused by gallstones. It can be caused by cystic fibrosis. I'm going to sneeze. As some examples to give you. So gallstones, alcoholism, cystic fibrosis are some of the reasons that you may see chronic pancreatitis. Next slide. It looks like we have this one little tiny slide on appendicitis. So on appendicitis, you can see there above the anterior iliac crest is what's called McBurney's point. And that is typically where you will find the most pain. The pain will be worse as you palpate the abdomen down. The pain will be much worse for a patient in and around that right side there in what's called McBurney's point. You can see the difference in where the umbilicus crosses there at the top there of the iliac crest. The McBurney's point is just below that. Now, as a pediatric nurse, I will tell you that if you were to ask a 5, 6, 7, 8-year-old, 9, 10-year-old child or any of those ages, tell me exactly where it hurts worse, they're going to be crying and writhing in pain, and they're not going to be able necessarily to pinpoint McBurney's point. But that is the correct answer for NCLEX, is that the whole abdomen is painful, but the pain is much worse in the lower right where McBurney's point is. Next slide. Okay, we're moving on to the liver. The nurse should evaluate results of which laboratory test for a client who has cirrhosis in order to plan for safe care? Urinalysis, serum lipase, serum troponin, prothrombin time. Interesting. So some of you said urinalysis, and the question is plan for safe care. Safe care. So we talk of safe care, you think, well, I don't know the answer to this, so let me think about my ABC, my airway, breathing, circulation of blood, prothrombin time and clotting. That's the correct answer. So when the prothrombin time is increased, it takes longer for the blood to clot. And this happens in cirrhosis because the liver in cirrhosis is not making the correct amount of blood clotting proteins. So this is a memorization kind of thing, cirrhosis, prothrombin time, because you're worried about blood clotting and you're worried about bleeding. Next slide will show you cirrhosis of the liver. I think it's pretty obvious that this slide in this picture was taken post-mortem, but you can see what a severe, severe case of cirrhosis this is. Next slide. Now in this slide, you can see ascites, and I am here to tell you that in cirrhosis, the ascites can be just that bad. When I first started in nursing a million years ago, I started off as an LPN. And my very first patient that I was assigned to had cirrhosis. And I went in the room, not even thinking. And I tell you, the patient looked exactly like that left-hand top slide, and their skin was as bright yellow as a school bus. In the next picture, you see measuring the abdominal girth. Now, what is important about measuring the abdominal girth, aside from making sure it's done daily? You need to make sure that the abdomen is marked and that you measure the abdominal girth, one, at its widest, and two, you measure it at about the same time every day. What you see there and what would happen to the client on the top left, in the bottom slide, you see paracentesis, and that is simply a draining of the excess fluid that is inside that abdomen. Next slide. So asterixis is something that you will see in cirrhosis patients with severe alcoholism. So you can see that it's a hand tremor. So when the wrist is extended, it's like a flapping bird. Obviously in a still picture, you can't see it, but that's what happens with patients that have severe cirrhosis, is they can't control their hands and their hand flapping. Asterixis is another symptom you will see with cirrhosis of the liver. Next slide. I think we're moving to something different. Yes, we are. A client has a PRN prescription for loperamide. The nurse should plan to administer this medication if which finding is present: constipation, abdominal pain, episodes of diarrhea, hematase positive nasogastric tube drainage. Okay. So 40% of you weren't quite sure what to do with this question. 60% of you got it correct. What if I was to tell you that loperamide is Imodium, and Imodium is used for episodes of diarrhea? Not much else to say about Imodium except it's used for diarrhea. Next slide, I think the last slide. Okay, thank you. A client is taking Ducasat sodium. Which should the nurse monitor to determine whether the client is having a therapeutic effect from this medication? Abdominal pain, reduction in steatorrhea, hematase negative stools, regular bowel movements. Perfect, absolutely. So you all know that that's cholase. So regular bowel movements, cholase is a stool softener, and it is used for constipation to soften the stool. And I think you said that's the last slide, Devin.
Correct.
Okay, so folks, we are ahead of schedule, which I think is nice. I believe that Dr. Silvestri at some point in the day has a few more slides that she needs to do from yesterday. Is that true? Dr.
Yes,
Elmore?
that's true. That's true. So this is actually really good that we're ahead, Eileen.
I was rocking and rolling, Angie.
Yeah, I love it. Loving it. So, and then you'll be done a little bit earlier too, which is nice.
Right. So is is Dr. Silvestri going to go at the end of the day or in between here?
What we will do is after break, we'll go into renal and eye.
Okay,
So they'll have to move over to the next link. So if Devin, if you could throw that in the chat, that would be great. And then after that, I'm going to do the musculoskeletal from yesterday.
okay,
And then after that, Linda's going to do safe, effective care. And then after lunch, we'll do general NCLEX stuff.
okay, great,
So,
great.
all
So
right.
about 15 minutes?
Yeah, let's do 15 minutes. Let's come back at 9:50 and you'll go into the renal and eye link.
Mm-hmm.
All right. Thank you, everybody.
Thank you.
Okay, bye-bye.